Thank you for joining Cancer Support Community Atlanta for Interventional Radiology and Cancer Treatment, facilitated by Dr. Jason Levy with Northside Radiology Associates and moderated by Dr. Gena Volas-Redd with Georgia Cancer Specialists. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs. Welcome everyone to today's program, Interventional Radiology and Cancer Treatment. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include virtual support groups led by licensed mental health professionals, stress reduction classes like yoga and Tai Chi, a monthly nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and education programs like these. And if you ever missed a live event, we invite you to visit the video tab of our website where you can find recordings of past events. As a reminder, everyone will remain on mute for the duration of today's program. We invite you to enter questions into the program chat box, which Dr. Volas-Redd and Dr. Levy will address at the end of the program. I'm excited to welcome today's program moderator, Dr. Gena Volas-Redd. Dr. Gena Volas-Redd is a board-certified medical oncologist practicing with Georgia Cancer Specialists at the Canton and Kennestone locations. Dr. Volas-Redd completed her fellowship with the Hospital of the University of Pennsylvania in Philadelphia and Emory University Hospital in Atlanta. She's a member of the American Society of Clinical Oncology and the Society of Neurologic Oncology. Dr. Volas-Redd has a special interest in brain cancer, brain tumors, and cancer genetics. So with that, welcome Dr. Volas-Redd, and I will pass it off to you to begin today's presentation.
Great. Thank you. Thank you to all to allow me the opportunity to moderate this wonderful program, and this amazing person, Dr. Jason Levy, has been a colleague of mine for years, but more so in the past 8 years when we affiliated with Northside Hospital Cancer Institute. And even though he's just across the highway on 285-400, I can tell you that he's right there for me and for my patients, regardless of the distance. But he is an invasive radiologist. We call him interventional radiologist, or in the hospital, we call them IR. And he's been a lead partner at Northside Radiology Associates, and he's been practicing since 2001. And I have 1 year on him because I started in 2000. He is a member on his executive council and in his group. He is named Fellow of the Society of Interventional Radiology. And when you're a fellow, that's top-notch recognition nationally and internationally. And again, it's just for a tiny few percent and fraction of patients, of physician membership. He also has FSIR distinction, and he's lead author in a study on bone metastasis, and this was chosen by his National Society for Abstract of the Year, and he's one of Atlanta's top docs for the past 8 years. So without further ado, I'm gonna let him take over this screen, and I'm gonna mute me, and I'm gonna stop my video. I will come back at the end for any questions that you guys leave in my chat box. Anyway, enjoy the program.
Thank you, Gena. So I appreciate everyone coming and hearing about interventional radiology. So this is important to talk about interventional radiology because in part, many people do not know what an interventional radiologist is and what an interventional radiologist does. In fact, years ago, the Society of Interventional Radiology did a study and found that less than 2% of the American population actually knew what an interventional radiologist was. So I'm going to basically break down what an interventional radiologist is. And part of that is sort of talking about what an interventional radiologist isn't. And the term radiation or radiology is in 3 sets of doctors' titles, if you will. And that is radiation oncologists, and radiation oncologists are not interventional radiologists. They are a different type of doctor. They use radiation to help treat different types of cancer. And then there are diagnostic radiologists, also not interventional radiologists, and those are radiologists who use X-rays, MRI, CT, and ultrasound to diagnose disease. And they're typically less patient-facing, so they typically read the images. And then finally, there are interventional radiologists. So interventional radiologists, similar to diagnostic radiologists, use those imaging guidance. So MRI, CT, fluoroscopy, X-ray, and ultrasound, but instead of using them and not seeing patients, we use them to do minimally invasive procedures. So here on the right of your screen, you see sort of an example of one of the fancy rooms that we use MRI, CAT scan, ultrasound, and fluoroscopy or X-ray to do procedures. And because we are experts in this imaging guidance, we tend to have very small incisions and typically lower risk, less pain, and shorter recovery times than other alternatives. So here I've given you sort of an example of the size of the incision. So forget all this part. I put in a big pen. Obviously, we're not going to be putting big pens in people's bodies, but I wanted to show you, to give you a reference of the size of a typical interventional radiology incision. And it's just this tiny, tiny little piece right here that I have between the arrows. So because of the small incision, it's extremely rare for us to have to require general anesthesia and add that risk. And the recovery times are very, very short for most of our procedures. Now, keep in mind, we are part of a team. So we are providing targeted treatments, meaning oftentimes maybe going after 1 or 2 tumors, but cancer is a systemic disease, which means that it's, we're treating the patient's whole body. And that's why we have to be very careful, and we have to work with our medical oncologists like Dr. Volas-Redd, who introduced me, and surgical oncologists. Here at Northside, we work very closely with Dr. Abdallah and Sir, some of our hepatobiliary surgeons, to treat patients for curative treatments as well as palliative treatments. So that's sort of a brief introduction to what an interventional radiologist does. And then we're here to talk about interventional radiology performing procedures for oncology patients. So also known as interventional oncology, or as Gena said, IR. Sometimes people who focus on oncology like myself call ourselves IOs, so interventional oncology. And we will see and treat patients really at many stages throughout cancer cycles, and hopefully not progressing, but in some cases we have to see patients in more of the end stage as well. So we can see them in the initial diagnosis, where an interventional radiologist may perform a biopsy, when therapy is initiated with ports, and then we will treat tumors that have either started in the liver or metastasized to the liver, started in the lung or metastasized to the lung, started in the bone or metastasized to the bone, and we treat kidney tumors as well. So first things first, biopsy. So I have some pictures here, and you can see, so here is a patient. This is each of these darkest structures here are the lungs. This structure here is the heart, all right? And this white nodule here, that is a cancer. And you can see this very thin line that I have the arrow pointing to, and that is a minimally invasive biopsy. So why do we do this? Well, obviously we need to make the diagnosis, but oftentimes in this day and age, our oncologists have to give personalized treatment. So the Dr. Volas-Redd will need tumor genetics, the tumor biology, and they can make a targeted, individualized treatment based on the information that I am helping them get. Next, we go on to once the treatment has started, and a good portion of patients need some sort of intravenous treatment, depending on the type of treatment. Most commonly it's going to be chemotherapy, but there are many other therapies out there. So interventional radiologists, as experts in image guidance, whether it's ultrasound or X-ray or CT, And catheter experts, since we're basically using catheters all day long, we place a large majority of the ports. So here on the left side of the screen, we see a surgically placed port, and it's kind of coiled up here in the neck. This is, you can see here, these are ribs. And then this same patient with a properly placed port in interventional radiology, we're able to save costs and have lower complications because of our ability to use these expert image guided techniques. So some of the most gratifying things that we do are actually tumor treatments. And the tumor treatments may have different types of goals depending on the patient and depending on the tumor and the extent of disease. So sometimes we're working in more a curative setting where we're trying to completely cure the disease, whether alone or in combination with some of our surgical or medical oncologists. Other times we're just trying to get control over a local area like the liver or the lung. And then finally, sometimes we're actually just treating pain and trying to improve quality of life for patients. So, tumor treatments. I'm going to start with tumor treatments where we're basically directly putting needles into tumors and treating them. So, cryoablation, killing it with cold, radiofrequency and microwave ablation, killing it with heat. So we've already talked about that we treat liver tumors, whether they start in the liver or have gone to the liver, lung tumors, whether they've started there or gone there, bone tumors, same thing, and then kidney. And again, it's very important to understand what our goal is. Usually it's tumor eradication, getting rid of the tumor in that area. There have been many advances in both cryoablation, cold, microwave, and radiofrequency ablation, hot, that allow for more controlled, safer, and larger ablation so we can treat bigger tumors if needed. So here's an example of a patient of mine that I treated years ago and is still cancer-free. This is about 8 years later. So this is an image, this grayish structure with white little lines in there, that's the liver. And we see this white rounded structure, and that's the tumor. And then we see me putting a small needle into that heats it up. And then immediately after, we see this very dark space, which means there's no more blood flow to it and means it's dead. Here we see it a couple months later, and here it is 8 to 9 months later, and this patient is several years out, still cancer-free. So this was a curative treatment for somebody with colorectal cancer, colon cancer that had spread to the liver. We also do arterial-based therapy. So instead of sticking a needle directly into it, we can do something called embolization, which is just a fancy way of saying we're putting things in through catheters through the arterial blood supply that feeds tumors to treat these tumors. So why are we able to do this? Well, we usually do this in the liver. And why do we choose to do this in the liver? Well, the liver is kind of a special organ that has 2 different blood flows to it. So it has the, as you can see, this bluish structure, that's the portal vein, and this reddish structure, that's the hepatic artery. So most organs only have blood flow. If you remember back in grade school, you learned that arteries bring blood to the organs, veins drain blood out. Well, the liver is special because it has 2 blood flows going in, and that includes the portal vein and the hepatic artery, the liver artery. So when patients have tumors in the liver, they tend to get more of their blood supply from the hepatic artery, and the normal blood supply to the tumor, to the liver rather, often will come from the portal vein. So we take advantage of that by getting into the hepatic arteries and directly feeding it. So here's an example of a sort of a cartoon showing us a procedure where we get a tiny little incision like the incision I showed you earlier. We get in, we get really far out, and this is the patient's body. As you can see, that's the liver, and each of these green structures are tumors, and we go ahead and treat those tumors by delivering, whether it's chemotherapy, or we can do internal radiation, something called yttrium-90, or for short, Y90, that has many names. It can be called SIRT, SIRT, radioembolization, yttrium 90, Y90. So here's just an example of a really great outcome that we achieved with one of our oncologists here at the Northside Cancer Institute. And this is a 59-year-old female who was initially diagnosed with melanoma, treated with surgery. And unfortunately, that was 1996. Unfortunately, 17 years later, she had a fairly massive recurrence with multiple cancers that have spread to the liver, spleen, as well as the chest. And she was treated from February to April of 2013 with something called immunotherapy. So helping, basically immunotherapy, and Gena might correct me later on, but what the oncologists do with immunotherapy is they allow the patient's own body to recognize the tumor as a foreign body, and these drugs will help the body clear away that tumor, okay? She presented to the IR, or Interventional Radiology Clinic, 4 months later to me in 2013. So I think we can all appreciate this is a PET scan, okay? And you can see the head's up here, the legs are down here. All right, so just to sort of orient you here, there's supposed to be activity in the brain. So what a PET scan detects is tumors and things that are very, very metabolically active or very, very hungry for sugar, basically. So everyone's brain's going to be working really, really well, right? Okay, I guess some of us may think that other people's brains aren't working too well, but everyone's PET scan is going to have a lot of uptake in the brain. And then they're going to have uptake in the bladder and the kidneys. However, these other dark spots, and you can see this liver here, this triangle here is riddled with dark spots. Those should not be there. So that should say post-immunotherapy. I am sorry for that. So right after immunotherapy, there was still a fair amount of disease. But sometimes immunotherapy takes time to work, so we gave it a little time. And this is before my treatment, the yttrium 90, or internal radiation, radioembolization. And you can see this is triangle again, or this structure here is the tumor. Some of these white things are just blood vessels, but you can appreciate there's still multiple dark dots scattered throughout this liver. So there's still a fair amount of disease here. So we did a procedure, and then you can see this tiny little catheter feeding the liver in September of 2013. All right, so what did we do? We followed the patient up with PET CT, and on the first PET CT, 3 months later, we still, well, there's definitely less disease, and in fact, there's less disease in areas that we didn't even treat outside of the liver. And then July, still less disease. The patient has received no further treatment after this time. So the last immunotherapy from the oncologist was in April of 2013. The last yttrium 90 was in September of 2013. And then we continued to follow her. And by April of 2016, the only activity was normal background activity in the brain, the heart, the kidneys, and the bladder. Here is that CAT scan. Same time, we can see none of those dark spots are still there. February 2018, she remained disease-free, and she remains disease-free today. So what happens here? And this is what's called an abscopal effect, which is just a fancy way of saying the immunotherapy worked in part because the interventional radiologist, myself, were able to deliver some of the tumor, kill the tumor, and it sort of initiated that immunotherapy to continue to work and work harder and see that tumor as a foreign body and basically make the tumor evaporate. So this treatment, working with the medical oncologist, led to a patient with well over 100 metastases be disease-free now 8 years later. So here's just sort of a time frame of April 2013, all these metastases. Here's my treatment. Here it's getting better in December. Here it's getting a lot better in almost 9 months later. And here we are in 2018 with no disease. Sometimes we will work with our surgeons, like I said earlier, okay? So this here is a structure. This is a liver, right? The white structure geocard.
Dr. Levy, I think you're breaking up on our end.
I just lost a little bit of your talk, Dr. Levy.
We sign back in.
Let's see, you were breaking up there. I think your screen might be
Let me-
frozen. Oh, I think he's going to come back and join us in a second.
While he's pulling up, there was a question, what is involved with treatment and what is actually done? He's explained the delivery through some arterial methods, and that's usually done with diseases like colon cancer and primary liver cancer. I can tell you with some other diseases like breast cancer that just say have one solitary metastasis to the liver, we have done just single courses of either radiofrequency ablation. And often we get these patients primed, ready to go for liver resection even. We use Y90, trying to get patients sometimes ready for liver transplant or liver resection for primary liver tumors. And we also use it for primary bile duct cancers called cholangiocarcinoma.
So am I back here? Just if.
I hear you.
All right, good. So yes, exactly what Dr. Volas-Redd was saying. So here's a case where we worked to get somebody to get a curative response with surgery. So I needed to basically convert somebody who was not a surgical candidate, which means that they would ultimately not survive from this, to somebody who is a surgical candidate. So here's the big, you could see this grayish area that's different than the normal area here, and the normal area here that's replacing a large portion of the liver. Here is my fancy mapping study. So this is sort of planning or mapping out my treatment. As you can see, this orangish area is where I plan on doing the treatment, okay? This is before I started, and this is about 4 months later, and a couple of things have happened. One, this tumor now is this smaller tumor, so it's much smaller. Two, this blood vessel, this white structure here, is nowhere near this anymore, so it makes it easier for the surgeon. And three, you've all heard that the liver regrows. Well, in this case, this is the part of the liver that's going to stay. It's much bigger, so it has helped regrow because of the Y90 or the yttrium 90 that we did. And Dr. Abdallah and Sir were able to take this patient to the operating room and get a curative response by removing the tumor. Sometimes we can act on our own in patients that can't go to the surgery in the liver. So here is a patient with colon cancer, and I showed you one where we put a needle into and ablated it. Well, this is the same thing, but instead we're going in through the arteries. So we're doing a Y90, a radiation segmentectomy. That segmentectomy, the liver has 8 segments, so we're basically removing one of them from the inside of the body. This patient was too old to have surgery and had too many, well, not too old, that's not a way you say it, is too many medical problems to have surgery. So we chose a little bit less invasive option for the segmentectomy. Here it is beforehand. Here is during the treatment. As you can see, we have a very nice isolated treatment in the liver. So those are some of the more curative treatments, or combination with our surgeons or our medical oncologists to get curative treatments, but we also do some palliative treatments as well. And this is one of the things, one of my passions is one of my many passions is treating skeletal or bone metastasis with combining it with kyphoplasty using cement and ablation, radiofrequency ablation by killing the tumor with heat. So here's just an example of a treatment, and we're looking from the side, sort of the same way you're looking at me from the side and we're looking at the spine, and each of these are vertebral bodies, but there's this one white area that's lighting up, and that's the area that we treated. You could see my small needles going in there, and then after I put in cement. So as I said, it's one of my passions, and this was an article that I published with some of my colleagues from other centers. We actually have the next version of this hopefully getting accepted for publication with the full cohort of 200 patients. Our goals are when we're doing this. So what are the problems when patients have had cancer that has spread to the bone? Well, one thing that happens is they can fracture, okay, and create a lot of pain and even worsen the patient's lifespan. A second thing that can happen is it can hit the spinal cord or other nerves and create really devastating effects. And then the third thing that happens is it causes a lot of pain. So we really want to eliminate those three problems when we're treating patients with this kind of therapy. So this is our study, and I show this just to show, you know, we were, even being in a community hospital, we did more patients than Duke, the Mayo Clinic, Sunnybrook Health Sciences in Toronto, Emory, UT Southwestern, so and Moffitt Cancer Center. So, you know, we were really on the cutting edge of this therapy. So what do we see? So basically the bottom line is we were able to see three important things. One is the pain was reduced within 3 days, okay? And that's really, really important because the standard of care for most of these patients is radiation, just external radiation, which takes 4 to 6 weeks. The second thing we were able to see is that it's the pain relief, the quality of life improvement lasted for 12 full months. So we didn't follow them longer because we didn't feel like we need to, but it worked fast and it stayed working. And then finally, here we see the quality of life measures also improving. We had no skeletal related events, meaning not a single patient in it, and this was in our abstract with 200 patients, developed a fracture, and not a single patient developed a neurologic sequelae during our treatments, which is very important. Especially we know that many patients, anywhere from 5 to up to 30% of patients, even when they're treated with radiation, develop fractures. So we felt this was very important information to get out there, and this is why we published the information, so that patients knew and that physicians knew that this is an option that is available for patients. So this is just an example of one of those patients that was in it. This is a 42-year-old female with breast cancer. This patient had, here we remember the same way you're looking at me from the side. So this is their spine. Each of these are the vertebral bodies of the spine, and one of them looks different than the other, and that's because a tumor has sort of chewed away at it. This was before radiation. Unfortunately, after radiation, the patient went on to have a fracture. So you see it sort of crushed down, and now her pain level was much higher. So we went ahead and treated this with heating up the tumor and then putting in cement. And guess what? The next day, her pain score went from a 10 out of 10 within 1 day to 4 out of 10, and she was out of bed and doing physical therapy. So really an astonishing result for a patient who was very happy with her outcome. So in conclusion, and I'm repeating this slide because it's very important to know that we are part of the oncology community. So we are providing targeted therapies, meaning very focal, very local treatments for local problems in patients with a systemic disease, meaning a whole body disease. So we work very closely, and we have to. You can't do interventional oncology without working very closely with your medical oncology colleagues, your surgical oncology colleagues, and all of the other oncology teammates that we have here at Northside. So I am going to stop the slideshow.
That was incredible, wonderful review of all of your amazing expertise. And I can tell you from my perspective, just having Dr. Levy and his team throughout 3 different hospital systems makes a cancer center that's spread over many counties, just very close. And we have developed a really amazing cancer institute with amazing providers, navigators, nurses. We have brought on the most skilled surgical oncologist in most of our disease sites. Working with Dr. Levy and the hepatobiliary team is Dr. Eddie Abdullah and now Dr. Melanie Soar. So we have almost every single day, we have a tumor conference dedicated to one specific site. This morning was head and neck, yesterday was abdominal. There's another colon cancer, head and neck cancer, I said, breast cancer, melanoma, sarcoma. So we always have interventional radiology chimed into our all of our tumor boards, just discussing where locally ablative techniques can be applied in their tumor site. So again, your healthcare is dependent on how many people are involved having an opinion. I would like to go through some of these questions and thank you for submitting them. And I think we talked about what exactly is the treatment that's going into the catheters. Y90 is yttrium, it's a radiation, and that is directed by and large to the liver through the arterial, the artery system and the venous system. There are some agents that within chemotherapy that are delivered to the liver specifically for some tumors, mainly hepatocellular cancer, which is a primary liver tumor, and also sometimes for colon cancer. And I can't remember when there's a burn and when there's a freeze and when there's a microwave. So I usually leave it to the interventional radiology to tell me which one's which. There's a question that came in about ovarian cancer. Ovarian cancer tends to really be focused on the abdomen, the peritoneum, but there will be some instances where some ovarian cancer develops painful bony metastasis, and sometimes there's liver metastasis. I'm not seeing a lot of locally ablative techniques for ovarian cancer to the liver unless there is pain. For instance, some pancreas cancers develop a lot of visceral pain, and sometimes the celiac plexus block is often used to help with pain control, because it's an organ that's behind, it's we call retroperitoneal, and that causes a lot of visceral pain that sometimes it's just really hard to get pain medications working, and dealing with all the side effects of the pain medicine is also challenging. There's another question that came in and asked, how do you determine if you've gotten enough material for a biopsy? Well, that's easy enough, because the pathologist will either tell you you have enough specimen and exactly what it is. And based on that amount, we send off for what we call next-gen sequencing genetic studies after the original biopsy is telling us exactly what we have, whether it's a relapse from lung cancer, whether it's a new lung cancer primary or other primary. And again, lung is challenging to get with biopsies, especially if it's sort of in the center or pretty high up in the lung. We can lead to some complications, but again, we have 3 amazing hospitals and support that's there 24/7 when needed, if there's any complications from biopsies or whatnot. So I think,
hey, Gena, can I cut in on on the ovarian cancer, rarely, and because Northside sees so many of those patients, rarely we will actually do some liver-directed treatments. I worked with one of the OBGYN oncologists who has since retired, Dr. Benigno, and we actually published a small paper in one of their journals regarding a small subset of about 15 patients that we did treat with percutaneous ablation in like you said, the rare situation where it's isolated to the liver. So we do have some experience with that, but it's like you said, it's not a common situation.
very good to know. So okay, there's another question that came. What is the rationale in selecting radioembolization over chemoembolization when treating unoperable tumors. And Dr. Levy, I'm going to let you take that, helping guide the medical oncologist. I can tell you from my perspective, if there's disease that's just focused on the liver, or the liver is very symptomatic with pain, I just pick up the phone and make the phone call and let them help me decide what they're doing, whether it's radiation. I can tell you, we try to hold all chemo, all immunotherapy during at least some of the radiation embolization. If it's Avastin and there's going to be a needle poke, we try to just sequence it in between regimens. Avastin or bevacizumab is one of the agents we use a lot in ovarian cancer, a lot in colon cancer, not ever in breast cancer. And so there's a bleeding risk that it's very minor, especially with small little catheters. So Dr. Levy,
Yes.
you can kind of comment how you choose which moiety to inject.
Sure. So it's kind of a little bit tumor dependent, and where the tumor is, how much of the tumor that there is, and without getting too much in the weeds, for a lot of the primary cancers of the liver, there is sort of burgeoning evidence that we're probably seeing better results with Y90. Now, that's not for every patient. Certain patients can't get the yttrium-90, the radiation. Certain patients have had Y90 and probably can't get it repeated and need a chemoembolization. So that's with that kind of cancer. With colon cancer, there is definitely some interest with chemoembolization using one of the chemo drugs that the oncologists use, irinotecan. There's probably more interest with yttrium-90, the radioembolization with that kind of cancer. But then you turn towards some sort of neuroendocrine tumors that go to the liver. And depending on the stage, more of those are tended to be treated with chemoembolization. So it's kind of dependent on the stage of the tumor, the type of the tumor, and whether or not they can even get yttrium-90 versus chemoembolization. So sort of a non-answer, but it gets a lot into the weeds of the type of the tumor and the stage of the tumor.
Very good. There was another question that came in. Can a patient ask their oncologist for an IR consult, and can a patient make their own appointment? That usually should be helped out by the medical oncologist. I know with each of the, at least with Cherokee, they have a consult date with the patient so that they speak with the whole team. For instance, if I have a breast cancer patient that has a relapse only to her liver, and her liver is just very much, seeded with liver metastasis, but that's the only site. I know at one point I'm going to send them for a Y90 consult, and I get that consult set up so that we can all be on a good timing as to the when, and if they're in between, say, oral chemo or IV chemo, I'll get all that set up so that everyone's in communication, because there's the mapping and then there's the procedure. We need to hold chemo. So that's what we have at Cherokee, and I know you probably have the same setup at main campus and at Forsyth.
Yeah, we have all Forsyth, Atlanta, and Cherokee all have the same setup. We see patients in consultation. Someone like Dr. Volas.
I'm losing you again. There's another question coming in.
We'll work with these docs to set the patient up.
Very good. This other question says, do I and Dr. Levy think that IR treatment can be used alone or in conjunction with another treatment? It all depends. For instance, if we're trying to get somebody ready for, say, liver resection, liver transplant with hepatocellular, that's primary liver cancer, that's when it's used as by and large independent and independent of any other therapy. But now that we've got new immunotherapy and Avastin combination therapies, we usually often do it in conjunction. So by and large, it's in conjunction with what we say systemic therapy, and whether that's hormonal therapy, oral therapy, IV chemotherapy, it's usually a paired event. And I think I got all of the questions in the chat box, and we have a good 10 or 15 more minutes of some questions that we thought would be good to sort of continue the dialogue. Is interventional radiology available for only certain cancer types? Yes, for the most part, but we see whatever loves the liver. So breast cancer goes to the liver, colon cancer, again, primary liver cancer, whether it's hepatocellular cancer or cholangiocarcinoma, those are liver specific spreads. We see melanoma to the liver. And sometimes patients are, as Dr. Levy mentioned, are on, immunotherapy in the process. I'm learning about ovarian cancer to the liver. We see it. It's a rare entity.
Yeah, and then like Dr. Volas-Redd, said, it does depend on the cancer, but really, so for instance, our bone treatments, our liver treatments, a lot of primary cancers will go to the bone. So we treat those bone cancer treatments or bone metastases with multiple different primaries. In fact, that primary cancers, in fact, that study that we published had, I believe, over 30 different primary cancers that had spread to the bone. So it's more a matter of, does the cancer go to the organs that we typically treat?
One of our big goals with our patients is to make sure that their quality of life is as good as it can be, and painful bony metastasis it's an awful lot to deal with. There's, oral narcotics, transdermal narcotics, there's pain, there's fatigue, there's nausea, there's constipation. So anything we can do adjunctively to help their cancer pain and their cancer journey. Again, a lot of these patients we're treating them for palliation and palliative intent, but we want to keep these patients alive as long as we can with a great quality of life, and whatever adjunct we can use, we try to really just be mindful of all of these issues. It's complicated, but we practice in a multidisciplinary fashion on a daily basis.
Yeah, the multidisciplinary fashion is, absolutely crucial. It's one of the sort of challenges to being, or lack of challenges to being in a big center like this and having so many different specialties working together really allows for the best ultimate care of patients. People call it the 4 or 5 pillars of oncology, and one of the things my society is trying to do is say, hey, we're one of these pillars. There are about 5 pillars, and we're trying to say, hey, we're one of these pillars, but there's still surgical oncology, medical oncology, radiation oncology, and then we all work together to get the best outcomes.
Thank you. There's a question, how do I know if I'm a candidate for cryoablation? I'm going to let you take that one.
So specifically cryoablation is going to be sort of institution dependent on whether you're going to do cryoablation. Typically, the cryoablations that I do, killing things with cold, are either in the lung with lung metastases, or some of the bone tumors that we will treat, especially if we're going for more of a curative event. And then finally, kidney cancers, primary kidney cancers. I don't usually do cryoablation in the liver because sort of heat works better in the liver in my experience. So it depends though. Typically those therapies that we were talking about, whether I stick a needle directly into it versus going through the arteries, some of that depends a little bit on size of the tumor, because the smaller it is, the easier it is to treat with just going through the needle, and also the location of the tumor. But as it gets bigger, you have to end up going through the artery.
Very good. I know in some cases we don't biopsy kidney tumors. They just go on for, we think we're biopsying, but they actually just set up a cryoablation without a biopsy. And I know that's one of the rare diseases that If it looks like a kidney cancer and it's small, they usually are just doing cryotherapy only, as opposed to any type of removal, or there's medical reasons not to actually send patients for a big surgery such as kidney removal, even though it's done most of the time robotically. There was another question that came in that says, when you treat the bone metastasis, where do you enter on the body?
So it depends on which bone. If we're going, more often than not, it's in the spine or the pelvis, just because there's more bones in that area. So that's where the cancer typically will want to go to. So it's going to depend on where it is. Usually in the spine, we go through, if you will, the spine has a sort of a cage around the spinal cord, and that cage is filled with bones. And so we use the back of it. So we go in through the back and we make small holes in the cage. So we're going through the cage itself to treat it. And then actually one of the reasons why we saw no fractures is because when we're done, we put some cement in there that'll sort of reinforces the bone. So that really gives us the advantage of avoiding fractures down the road.
One of the things that that you didn't mention as one of your expertise that we send very frequently is bone marrow biopsies. We used to do them in the office just with some local lidocaine, and it's a much better setup. I mean, I would be signing up for that. A little conscious sedation, a little happy juice, and lots of topical lidocaine. But lymphomas, myelomas all require bone marrow biopsy, sometimes frequently. So it's just a one little quick order, and you guys do an amazing job. We have the pathologist right on site to make sure that there's enough specimen in the spicules. So that's another. And again, that's on your backside. Your patients are lying prone on their belly, and they do it under CT guidance, where we were taught how to just do it blind based on landmarks. And I think it's much more precise and much more user friendly, because you guys can just go right for the target with lots of numbing medicine and sometimes a lot of sedation, which I would want personally. So I'm gonna keep on going. If no other questions keep coming, we've got some other questions that I wanted to entertain. We talked about cryoablation. Oh, okay. I will probably answer this one. Are there any possible side effects with interventional radiology? Again, sticking needles, whether you're burning, whether you're using, you're freezing or Y90. We've developed a really good system with our IR colleagues of once, mainly for Y90, when they're set up, you are killing portions of the liver, and that causes pain a couple days later. So we usually bring the patients in, set them up for IV fluids at least 2 or 3 times after the fact. And don't they have to distance themselves for about a day because they're radioactive, Dr. Levy, if I remember correctly?
Yeah, so about 1 out of 4 patients will report pain. More often than not with Y90, those patients will have a sort of fatigue and a little bit of loss of appetite, similar to like a chemo treatment, and that is self-limited. It goes away. Some patients don't get it at all. The precautions are basically very easy to follow because yes, technically you are emitting a small amount of radiation, although we know that most of really the harmful radiation only travels 2 millimeters. But there are some very simple things that patients can do to protect those around them. So we usually tell them that for the first 3 or 4 days after a Y90 procedure that they don't make food for others, so they can prepare foods for themselves, but they don't prepare food for others, and that they use what we call the arm's length distance rule. So, if you're going to be with somebody for a long period of time, you shouldn't be able to reach out and touch them. You can, short periods of time, it's not a big deal. When I'm in the room, I will be holding up the Y90 like this. So I'm looking at it, so it's really for a prolonged period of time. And that's for just a couple days. And then we also, one of the nice things to help flush it through the system is just drink a lot of water. drink 6 to 8 glasses of water, which is probably a good thing. Dr. Volas-Redd can say, I imagine for her patients, that that's a good thing to do no matter what.
Always. Very good. So there was another question came in. Is the biopsy always initiated and ordered by a medical oncologist? And I'm going to venture to say it's by and large not usually ordered by myself. It's usually ordered by the people who are referring to us. Say for lung cancer, they usually have biopsies that are already done. So the pulmonary folks are a big source of referral to the invasive radiologist if they cannot get the biopsy done by bronchoscopy or by endoscopic bronchial ultrasound and biopsy. There are lesions that are on the peripheral part of your lungs that IR is a much better get in terms of feasibility and safety. So if there is a liver metastasis in someone that has perhaps colon cancer or breast cancer, usually the monitoring doctor, the oncologist, are the ones who order that in follow-up. So it's really a big mishmash of folks who are all participating, but new cases coming into medical oncology, if they're advanced, usually have a biopsy already. If it's someone who has had curative disease and then they have a relapse, or if there's an early stage disease and there's something that doesn't look right, we are the ones ordering many of the biopsies. But again, it's done. Who's not ordering biopsies, I'm going to imagine, are their internists. They'll usually just ship them off to us to do, an oncologic workup.
Yeah, I would agree.
Oncologists are big orders of biopsies as well.
Yep. Surgical oncologists, pulmonologists, usually specialists are the ones who refer the biopsies to us.
So, well, I think I got all of the questions answered on both the chat box. We have a few more minutes to wrap up, but if there's no other questions, I want to thank you everybody for your time, and Dr. Levy for your expertise, and Katie and her whole team for navigating us through this program. And I hope we get to participate down the road. Thank you for joining us.
Yeah, thank you
everybody.
both. Thank you, Dr. Levy and Dr. Volas-Redd. That was such helpful information. We're getting a lot of positive feedback in the chat box, folks saying this was so helpful and wonderful. So thank you both for your time and expertise. I will remind everyone a recording of today's program will be available on our website, cscatlanta.org. Probably next week you can find a recording under the videos tab. So before we go, I'm going to invite you both, Dr. Levy, Dr. Volas-Redd, to share any kind of final thoughts. Dr. Volas-Redd, I'll let you go first.
Well, I can tell you for 20 years, it's been, or 21 years, I have to tell you, it's 21 years, I can't believe it. It's been an amazing journey through just seeing where cancer is coming. We were just giving chemotherapy 21 years ago and sometimes hormonal therapy, but over the past 6, 7, 8 years, we're moving on to such more sophisticated therapy, immunotherapy, targeted therapy, whether it's by IV or oral. And it's just never a day that you're not reading, not going to conference. And it's been a great program that we're involved with. Again, there are multiple oncology practices under the Northside umbrella, and the hospitals really provided just great framework of allowing us to deliver the best possible care for really sick patients. And it just makes the journey just a little bit easier, knowing that we've got great backup and amazing, very well-trained, published people that are just great to work with and amazing colleagues. And it just makes every day just a special day to come in and help, provide just the best possible care to these patients. And I always say you can never have a bad hair day doing what we do.
Dr. Levy, any final thoughts from you?
Yeah, I kind of feel like I always have a bad hair day, but yeah, I agree. I mean, the field, our field, interventional radiology, has grown so much alongside oncology. When I first started, there were small numbers of studies out there. Nowadays, I mean, you look at stuff, treatment in the liver, there's just so many things going on in combination therapies. working with some of the other teams like we talked about, so the hepatobiliary surgeons, the oncologists, it's just really, really rewarding, and we've had really good outcomes, and that's the most rewarding part of it. So I enjoy being an interventional radiologist, and I hope we can, help more patients.
Great. Thank you both. And for more information on Dr. Levy, you can find him at northsideradiology.com. And for more information on Dr. Volas-Redd, you can find her at Georgia Cancer Specialist website, Georgia Cancer, that's gacancer.com. Thank you both again. Thank you everybody for joining us. Everyone have a great afternoon, and we hope to see you soon. Take care.
Thank you for having us.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.